uterine corpus. And that would, of course, be managed in a different way. But in all other patients who have a glandular abnormality on Pap, we want to proceed to colposcopy. We should still consider adding endometrial biopsy if she has any symptoms or risk factors that would make us worry about endometrial cancer. So this could include obesity, perhaps irregular vaginal bleeding. If she's over the age of 35, she could have endometrial cancer. So let's carry this forward and look at an example case. Here's our colposcopic exam following that Pap test showing atypical or showing adenocarcinoma in situ. And what we see here is this is a very magnified view. The cervical os is here. This is looking at the anterior lip of the cervix. And you'll notice this clear mucus in deep, wide gland clefts. When you have a real colposcope in front of you, you have depth perception. When I show a photograph on slide, you lose that. But in reality, this is a large hole. It's a cleft going down into the cervix that's big. It's not expected to be large like that. And in the talk that Dr. Dara gave yesterday on glandular lesions, recall that that would be one of our many warning signs for a high-grade glandular lesion or a glandular cancer. So how should we proceed? We would do our biopsies, and based on the biopsies, we'll pick our management plan. Now we know that the initial Pap test that I showed you a few moments ago was read out as adenocarcinoma in situ. Our level of worry that she could harbor invasive cancer is very high. And for that reason, the algorithm is very simple. We rule out invasion. This means we look with colposcopy. As long as there is no obvious invasive disease, we would proceed to a diagnostic excision. The goal here is to provide an intact biopsy to our pathologist, a biopsy that has histologically interpretable margins. So if we were to do a loop excision, for example, this would have a cautery artifact where heat at the periphery can make it very difficult for the pathologist to know if the margins are involved or not. And so what the algorithm really prefers is that we provide our pathologists with a specimen that does not have cautery artifact and that is in one piece. For all intents and purposes, this usually means doing a cone biopsy with a scalpel in the operating room rather than an office procedure using an electrosurgical excision. If the Pap test was glandular but of a lesser severity, so this could be read out as atypical glandular cells not otherwise specified or favoring neoplasia, our algorithm is a little different. We will proceed to colposcopy, do biopsy.